Good evening, everyone. I am Arpita from IGCP Group, and it gives me great pleasure to welcome you all to today's special webinar on the occasion of World Retina Day. Our session for today is Ocular Clues to Systemic Diseases, Retina as a Window to the Body, a fascinating topic that highlights how the eye can reveal much more than just vision problems, often serving as a mirror to overall systemic health. We are honored to have with us our eminent speaker for today's session, Dr. Kuresh Muscati, sir, a highly respected name in the field of ophthalmology. Sir holds an MBBS, MS, DOMS, FCPS, and FICS, and is a distinguished consultant ophthalmologist at Muscati Eye Clinic, Mumbai. With decades of rich clinical experience, he has contributed immensely to advancing eye care and has been a guiding force for both practitioners and students alike. Today, he will help us understand how the retina can provide vital clues to systemic diseases, reinforcing the importance of early detection and multidisciplinary care. So, without any further ado, let's welcome Dr. Muscati and dive into the enlightening discussion. Over to you, sir.
Uh, Thank you, Arpita, and I hope my slides are visible.
Yes, sir, visible.
Okay, apologies for the slight delay because of some network problems. So as Arpita said, the topic on World Retina Day is really fascinating. How the retina can tell us so much about what is going on. And in my 4 decades of practice, I've often seen this. I've looked into the retina of a patient and told them that you seem to have diabetes. And he says, no, doc, I don't have diabetes. I'm quite convinced. And I tell them, when did you have a last checkup? And the last checkup was 10 years ago. So I advise them, please get your blood sugar done. And lo and behold, the blood sugar is 400. And they didn't realize it. So it's not only diabetes, it's blood pressure, it's the blood dyscrasias, anemias, leukemias. We'll talk about it all in the next 20-25 minutes. But it's a really fascinating thing that just looking through the eye, we can diagnose so much of what is wrong with the patient. So we need to know a little bit brief about the anatomy. So the retina has got 2 million cells. Retinal cells, they're all connected to the brain. So every cell has got like a nerve, like a TV cable. And all of them meet in the optic nerve and then go towards the brain, where the brain interprets the images that we see. So as you can see in the picture here, the retina is made up of rods and cones. The cones are cells which are responsible for day vision, the rods for night vision or when we are in darkness. And the retina is composed of 10 layers. We won't go into the details, but the total retinal thickness is composed of 10 layers. And it's at the back of the eye, like the old film camera, where the film was at the back of the eye. So if you can, for those of you who are old enough to remember non-mobile ways of taking pictures, this is the retina at the back of the eye, like a camera. So the commonest cause that we diagnose is diabetes. Diabetes causes many things in the eye. It can cause cataracts, glaucoma, dry eye, fluctuation of vision. Eye muscles can get paralyzed due to nerve damages, third or fourth or sixth nerve. But most important, it is also can cause bleeding or hemorrhage anywhere in the eye. As you can see, a minor trauma can cause so much of ecchymosis or blood clots in the orbit, in the eye. But we are concerned about the retina and optic nerve because that is where it can cause blindness. So what is diabetic retinal disease? First thing we must remember, I get patients who say, but doctor, my blood sugar is 110. It is under control. How can I get diabetes eye disease? So the longer the duration of disease, the more the chances of retinal affection. If you have had diabetes for more than 10 to 15 years, even if it's been under excellent control from day one, they still have 50% chance that your retina will get affected with excellent control. The worse the control, of course, the more the chances of retinal affection. That's why we say that all diabetics must visit an eye doctor for examination of the retina at least once a year, even if they have no symptoms. Because when do they get symptoms? When you see that black dot in that picture that I've shown, which is called the macula, and in the center of that of the macula is the fovea, the most sensitive part of the retina. So if this area is affected, if this gets edema, yes, vision will get blurred. But if you get hemorrhages and exudates in other parts of the retina, the vision may still be normal. But it's a warning sign that I need to intervene with laser, with injections to prevent the vision loss. So that's why a diabetic should not wait till the vision is blurred. They must go for an annual checkup at least. And if I find hemorrhages or blood or cholesterol deposits in the periphery, I may call you once in 6 months or once in 3 months. So symptoms that a diabetic patient may get may be floaters, maybe blurring of vision. Some areas of the field of vision may become dark if there is hemorrhage over there. Alteration in color perception, because the retina is responsible for color perception. So they don't see colors as well as they could. And later on, of course, if hemorrhages have set in, there may be blindness if untreated. And the nerve of the eye can get affected, giving rise to a pale white disc, which is called optic atrophy. The nerve is pale or white. So this is diabetic retinopathy. This is the pictures of diabetic retinopathy where you get blood clots, as you can see, and these yellow marks that you can see are hard exudates or cholesterol deposits. So these, by looking at the retina, I can make out whether the hemorrhages are superficial because they are flame shaped, or deep, then they are round hemorrhages. So I know where the hemorrhages are occurring as well. So basically, diabetic eye disease is divided into two or three parts. One is where, as I told you, the macula is involved, in which case you get macular edema. We do a test called OCT, like a CT scan of the brain, we do a CT scan of the retina. So this is the normal macula. It shows like a dip, like mountains on both sides and a dip or small valley. This is the normal macula as it appears on OCT. It's color coded, so we can see the different layers. If there is edema or waterlogging, then instead of a dip over here, you get a small mountain here raised, and this black spots with green dots inside is the waterlogging in the macula, which will give blurred vision. So you can get diabetic retinopathy with macular affection or without macular affection. Now, early stage of diabetic retinopathy is called NPDR, or non-proliferative diabetic retinopathy. That means you get hemorrhages, you get cholesterol deposits, but you don't get strings or fibrosis which pulls on the retina. So this is non-proliferative. You can get exudates and hemorrhages seen over here. This is the stage where we need to see the eye doctor and intervene. So other macular changes in NPDR or non-proliferative diabetic retinopathy, which is the early stage, the blood vessels may close down, a condition called macular ischemia. So here you can see the macula is looking very dull. The blood vessels have all closed down over here. And in OCT, I told you we have something new last 5 years only called OCT angiography. So without actually doing an angiography, an invasive procedure, we can see the macula layer by layer and decide whether there is this black area which shows that ischemia. And this is the picture showing hard exudate, these cholesterol deposits in the form of a ring. So that's called circinate retinopathy. Circinate means in a circle. In the center of that, there is a hemorrhage. So these are exudates and hemorrhages which can occur. You can get macular edema and macular ischemia. Vision will be blurry if the macular is involved. Suppose you neglect this, you don't do anything, then you get what is called PDR. So first was NPDR, second is PDR. PDR means proliferative diabetic retinopathy. It's the more advanced stage of diabetic eye disease. Now what is happening is, first the retinal blood vessels were just leaking. They were leaking, so blood was coming out, cholesterol was coming out and forming hemorrhages and hard exudates. Now the blood vessels are bursting. When they burst, there is a signal so that new blood vessels get formed to replace those which are burst or closed. So those new blood vessels, what we call, are very fragile, and they can bleed not only into the retina, but they can bleed into the front of the retina in a jelly which is called the vitreous. If they bleed only a little, then you will see just a few dark floaters. But if they bleed a lot, it might block all the vision, which is called vitreous hemorrhage. So you can see this blood clot huge, and there's a blood clot in front of the retina. You can't see the retina. This is in the pre-retinal space. So the vision gets affected, vitreous hemorrhage occurs. So this is PDR. If this is still not attended to, then the hemorrhage will ultimately get absorbed, but it will form scarring. Scarring will pull on the retina. So you can see this picture here, all white like ropes. So it's pulling on the retina, and when it pulls on the retina detaches from the back of the eye, which is called a traction retinal detachment. Traction means by pulling, by force. So this is very serious, and both the central and peripheral vision can all go away because of traction retinal detachment. So again, to reiterate, it starts innocuously, few hemorrhages, few exudates, vision is normal, you didn't come to me. Then it became a proliferative diabetic retinopathy. There was hemorrhage, you thought vision is little blurred, maybe it's because of cataract or glaucoma, you did not come to me. Then scarring occurred, and scarring pulled on the retina and called a tractional retinal detachment, and entire vision was lost. So what is the treatment of diabetic retinopathy? If the macula is involved, we give a type of injection in the vitreous called anti-VEGF injections. VEGF means vascular endothelial growth factor. So we don't want new vessels to grow, because I said when new vessels grow, they are fragile and burst. So we give several injections. I have no commercial interest. Some of the trade names are Avastin, Eylea, Eccentrix. So this anti-VEGF medication helps to reduce the swelling at the macula, slows the vision loss, and improves the vision. So this is, you can see the picture of the injection needle going in the jelly of the eye in front of the retina. And this is one more picture of it injecting the anti-VEGF into the retina, into the vitreous in front of the retina. So these are given by injections, which are called intravitreal injections. If there is a lot of macular edema, I might give steroid injection also intravitreally to reduce the macular swelling. Then if there is a lot of hemorrhages over here, we want to contain this area. So this is a branch retinal vein occlusion. That means one of these vessels, vein, one of the retinal veins is occluded, closed down, and the rest of the area is splattered with blood. So then, and here in the middle picture, you can see central retinal vein occlusion. The disc is edematous, and there is hemorrhages all around the disc, 360 degrees, because the central main retinal vein is occluded. So for these vein occlusions, we give laser treatment. So this is the laser. We give it to the patient in a sitting up position or lying down position. And we give the laser and we convert ischemic areas into anoxic areas. So no oxygen goes there. So the central retina gets full perfusion. It's like you have 6 children. You starve 4 of the children so that the 2 most important children are given nutrition. So this is what we do by laser. So we destroy the retina on the sides, but the central area, which is responsible for 80% vision, we preserve. Now, if there is vitreous abscess, this is in the NPDR, non-proliferative stage. But if there is a chronic vitreous hemorrhage or retinal detachment, then we have to do a procedure called vitrectomy. We go in with 3 instruments. It's called 3-port vitrectomy. One instrument is a light pipe which helps me to see inside because there is all hemorrhages. One instrument provides the irrigation. So there is saline going in and churning up. And this third instrument is a cutter. It's like a knife. It cuts the vitreous, cuts the blood clots. And this irrigation is along with aspiration. So it sucks out the material from inside. So once we suck out everything, all the hemorrhage is sucked out. Then we put heavy oil like silicone oil to push the retina back into place. So it's a very major surgery, vitrectomy with silicone oil injection. So to summarize, management of diabetic retinal disease made huge advances in recent years. Better diagnostic gadgets like OCT and OCT angiography. We have excellent operating microscopes and lasers and vitrectomy machines and new medicines like anti-VEGF. However, what is best is prevention Excellent diabetic control, regular eye checkups with your ophthalmologist are the most essential because a stitch in time saves nine and prevention is better than cure to keep your eyes serving you well for as long as you live. Let's move on to hypertension. Another thing that I diagnosed by looking into the eye. So this was the patient I saw with papilledema. Papillos means the optic disc. The what you see in the center, that's called a papilla, is just the optic disc. Instead of being orange, it is blood red, and it is edematous, and there are blood hemorrhages all around. So the disc is edematous. Why is it so? Because the blood pressure is very high. So I looked into the eye of this patient who didn't know that he had hypertension. I said, "Sir, you possibly have hypertension. Let me take your BP." And I keep a blood pressure apparatus. It was 200 by 120. So in hypertension, you can get hard exudates like you get in diabetes. But more important, the blood vessels are silver wired or copper wired. They look like copper wires or silver wires. The blood vessels change, which is not so in diabetic. That's how you make out, though there are retinal hemorrhages and hard exudates in both, papilledema and changes in the blood vessels and soft exudates, cotton wool spots. You see those hard exudates I showed you in diabetes? These are soft exudates, almost like there is cotton, yellow cotton over here. So that is a hallmark of hypertension. So a trained eye surgeon will make out the difference. And where the arteries cross the veins, they compress the veins because the arteries are sclerosed. Looking at that, I can say that you have a chance of getting a heart attack as well, just by looking into the retina. There are other causes of non-diabetic retinopathy. You get these microaneurysms, retinal hemorrhages. I told you, depending on where they are, they could be dot, blot, or flame shaped, hard exudates, soft exudates like cotton wool spots, retinal vein abnormalities like venous beading, tortuosity, and IRMA, intraretinal microvascular abnormalities and new vessels. So these are all the entire gamut of retinopathy which can occur not only because of diabetes and hypertension, but there are other systemic causes. So if we rule out diabetes and hypertension, which should be on the top of the list, we need to look at other causes. So what are some of the other causes? So this is a patient I had with hyperhomocystinemia. So his homocysteine levels were raised. It can be associated with diabetes, but it need not be. So you ask for serum homocysteine levels. If you see these, like this is a branch retinal vein occlusion. In one sector, there are hemorrhages. This could be hypertension, diabetes, but if it is not that, I would do a blood test for hyperhomocystinemia. If it is so, then we can treat it medically. The other causes are anemia. If there is severe anemia, like you can see here, you can just hemorrhages, large blot type of hemorrhages. Blot hemorrhages are in the middle layers of the retina. Typically, you get this anemic retinopathy. Similar picture can come with leukemia and other blood dyscrasias like Hodgkin's, lymphomas, and others. Then HIV/AIDS. If you get HIV, if a patient is suffering from HIV or even other diseases, infective disease like syphilis, then you can get hemorrhages and exudates in the retina. So if you get hemorrhages, exudates, you ruled out anemias, hyperhomocysteinemias. If he's an intravenous drug user or has different sexual appetite, you must suspect HIV retinitis and get them tested for triple H. And you can get carotid atherosclerotic vessel disease. This is a typing error here, but carotid atherosclerotic. So this can tell you that the carotids are also occluded and the patient is in high chances of stroke or heart attacks. Some of the not so common causes of retinopathy: systemic lupus erythematosus. Usually it's associated with less ischemia and visual loss. Then antiphospholipid antibody syndrome, typically in women under the age of 50. They present with diabetic retinopathy like picture, but they don't have diabetes. Behçet's disease, which is an autoimmune disorder, and certain systemic vascular diseases such as polyarthritis nodosa, temporal arthritis or giant cell arthritis, vaginous granulomatosis, and some other systemic ailments. So these are some of the not so common causes of diabetes of retinopathy. So we follow a sort of algorithm. First, we check for diabetes. If it is not, it's not. We note that it is a non-diabetic retinopathy. We look, ask for medical history, ask for basic investigations like homocysteine levels, CBC to rule out anemia, hemoglobin levels, and appropriate management. May refer it to an ophthalmologist, look at the visual fields, document with retinal photographs, we take further history, look for the retinal vein occlusions, and then we need to work hand in hand with the physician needs to work hand in hand with the retinal specialist or the ophthalmologist to get to the bottom of all these patients. So it is truly said that the eye is the mirror of the body, and retina is the mirror of many systemic ailments like diabetes, hypertension, blood dyscrasias, anemias, hyperhomocysteinemias, and so on. Thank you so much, and I'll be very happy to answer questions. Over to you, Arpita.
Thank you, sir. Thank you so much for the insightful session. Now, I would request all our audience, doctors, if you have any queries, kindly put it in the chat box. There's a comment box where you can put your comments, and I will be reading them out to sir on your behalf. Okay, sir. So I've received a few questions. First one is from a physician. So it's writing, it's from Dr. Sharma from Gwalior. He is writing that, sir, being a physician, how can we, along with the ophthalmologist, collaborate more effectively in managing our patients where retinal findings suggest any systemic pathology?
So, first of all, sir, I would congratulate you if you keep an ophthalmoscope and train yourself on how to look at the retina. That would be wonderful. If you treat diabetic patients at all, tell every diabetic patient of yours that they must see an eye surgeon before they see you the next time. So they have full faith and trust in you. So if you send them to an eye surgeon, we dilate the pupils and we look in the periphery also. So even if the vision is fine, we can detect diabetic retinopathy and treat it before it is very late. We ophthalmologists would be happy to keep charts of eye diseases showing the retina conditions in your clinic so that your patients can see them and realize that they need to see an eye surgeon. We need to work hand in hand, sir, because alone we neither you nor I can remove the scourge of diabetes, hypertension, and others. Thank you.
Thank you so much, sir, and thank you so much, Dr. Sharma, for your question. Moving on to the next question from its Dr. Sanjeev Singh, sir. Sir, what would you recommend as a practical screening schedule for systemic disease patients like diabetics or hypertensives to ensure timely retinal evaluations?
So I would again say that if you tell all your patients that they must come once a year, they must go and see an eye doctor. Those who are diabetic and hypertensive both, once a year if they come and see an eye doctor is enough. Because if I find no changes and the retina is absolutely healthy, I will say you're fine, come after a year. But if I find a few changes and I want to observe, then I might call them after 6 months or after 3 months and intervene only if I need to. So if you, because most diabetic or hypertensive, many of them don't even know that the eye can get affected. So they never come to an eye doctor. So that is where we need to work hand in hand. Thank you.
There is another question. I think sir is also a general practitioner. Sir is asking for general practitioner and non-ophthalmologist. What are the key ocular symptom or signs that should prompt an urgent referral to an ophthalmologist?
So if the patient, if, or the ophthalmic signs, if the patient is persistently sees floaters, or the patient has transient blurring of vision, or a blurring of a side vision, or central spot scotoma like thing, then you must refer, because that all these are signs that there is hemorrhage either in the periphery or in the center of the in the macular area there is edema. So these could be, so if the patient has diabetic, hypertensive, any complaints of either floaters or blurred peripheral vision or blurred central vision, you should refer the patient to an eye doctor. Thank
Sir,
you.
the next question is from Dr. Himani. She wants to know how has OCT, OCTA, or fundus autofluorescence changed the way we detect subtle systemic disease manifestation in the retina?
So it's a good question. See, I think what has happened is with advent of technology, the clinical skills of many an ophthalmologist are going down because every diabetic they suspect they put this. See, now we have wide field fundus cameras. That means through the pupil, even without dilatation, we can take almost 360-degree picture of the retina, blow it up on a large screen on TV, and examine every detail. So the clinical art of ophthalmoscopy is going down a little bit. And autofluorescence was a test we used to do, but now it's with OCT coming in and OCT angiography. Autofluorescence gives much less information than OCT and OCT angiography. So these are being used, but ideally the eye surgeon should first clinically diagnose and then subject them to these tests. Thank you.
Right, so thank you so much. It's another question. I think it's from Dr. Richa. She's also an ophthalmologist. What strategies have you found most effective for establishing strong referral pathways and communication, especially between ophthalmologists and our endocrinologists?
So, the tragedy is that ophthalmologists have more free time than the endocrinologists because there are fewer endocrinologists. So, the endocrinologists are also busy. They get patients with 400, 300 blood sugars, very, very worried. So, they are so busy telling them how to bring it down that many times they don't have the time to tell them go and see an eye doctor. So I always tell endocrinologists that just keep a chart in your clinic which just says if you have diabetes, please see an eye doctor once a year. Just a small board over there. Then the patient will read the chart in the waiting room, come and say, Doctor, why did you ask me to see an eye doctor? Then they can explain so that they will not forget. And we have told them that through our association, we are willing to give you free of charge charts without any doctor names, just a chart from the association saying diabetes can cause eye disease. Please see an eye doctor. But somehow there is reluctance to put up these charts there. We have a long way ahead. Thank you.
I think that was a very important question, and the answer was really very helpful. I hope all the like endocrinologists over there they follow it, sir.
Thank you.
Uh, so one last question. Do you see the role of AI-based retinal imaging expanding in a routine systemic disease screening, and how should we, the practicing ophthalmologists, prepare for these shifts?
You like it or not, AI is already come and it's coming in a big way and it's helping us. See, for example, the institutes have set up a rural screening program. So, can you imagine a village which is 200 kilometers from Mumbai or Calcutta and no eye doctor goes there ever? So, they take a 10th standard pass student, 10th standard pass, train him in basics of how to take up, and they give a traveling fundus camera which is portable and it's wide field. So without putting dilating drops in the pupil, he goes there and does a blood checkup of all the 200 patients in that village. 200 adults, blood screening is done. So he knows how to do blood screening, and just with the colorimetry, he knows who is a diabetic. He puts all the diabetics in front of the camera and just clicks the pictures. The pictures are remote controlled, sent in real time to the eye hospital 200 kilometers away, where earlier an eye doctor used to sit and see. So out of 200 people in the village, say 30 of them have diabetes, 30 pictures are sent. So that eye doctor used to see 30 pictures. Now we have a computer which sees 30 pictures, and the computer is better than the eye doctor. So no human intervention because of AI. The computer can screen and find diabetic retinopathy in the pictures, and it tells that technician, the 10 standard pass boy, send patient number 4 and 7 to the eye hospital. So out of 30 pictures, only 2 patients are required. So that fellow puts them in his van and takes them to the eye doctor. So AI is a big boon. It frees up the eye surgeons to do lasers and to do injections, not to diagnose. For diagnosis, a 10 standard boy and a computer is enough. Thank you.
Thank you, sir. Thank you so much. I would like to thank you for answering all the queries, sir. And yes, before closing the session, on behalf of the IGCP group, I extend my heartfelt gratitude to you for this such an enlightening session, and especially for highlighting the importance of interdisciplinary collaboration in patient care, like the role of an endocrinologist. That was such an important point, sir. Thank you, sir. Thank you so much for bringing all these points. I hope all the audience who have joined for today's session have been benefited with it. Thank you, sir. Thank you so much once again. And
Thank you.
we
Goodbye.
look forward for more sessions with you,
Yeah.
sir. Thank you. Thank you so much.
Okay. Goodbye.
Bye, sir. Take care.